My dear postgraduate students, we shall continue with our approach to bleeding disorders. We shall be touching upon the bleeding and the clotting time as investigations. This is the physiology behind the pathology of. Whenever there is going to be a rupture in a blood vessel, we all know that it is lined by collagen and there is an endothelial lining superior to it. When there is going to be a rupture, immediately there is an outpouring of blood. The RBCs and the tenacious plasma tend to form some kind of a block initially, but this is not sufficient. And in the meantime, you find that the platelets are brought into the region, they get activated. Ultimately, there is a fibrin mesh that is getting formed. So this forms something like a brick and a cement, which is stronger to stop the bleeding. Now we go on to the bleeding time. This instrument is called the lancet. The lancet has got a sharp cutting edge and then it is designed so that you do not over penetrate. There is a blotting paper which you should be having in mind. The test is done at the forearm on the anterior side and the BP cuff is inflated up to 40 millimeters of mercury. The prick has to be 1 millimeter deep and because of the cut, it can be a few millimeters wide. Courtesy Labpedia. Now, what is the pathophysiology of the clotting? You find that there are three stages. One is initially the vasospasm that I had explained. Second, there can be a platelet plug formation. Third, after this, you find that the coagulation factors are brought into force. At the same time, you find that there can be the intrinsic and the extrinsic pathways. Ultimately, you find that fibrinogen is getting converted into the insoluble fiber. So this is the basic clotting mechanism. You can go back to the physiology and the pathways. Now, this bleeding time can be done, one, to assess the platelets, because after all, they are supposed to form the plug and the fibrin. Secondly, creating an incision itself can sometimes lead to the cessation of the bleeding because there can be an opposition of the edges. Von Willebrand's disease is important. It is there in the subendothelial collagen, as a result of exposure of which you find that the von Willebrand's factor is brought into action. However, you find that the entire test lacks specificity and sensitivity. Specificity means for what purpose it is being done, and sensitivity is however many times you people do, it has to produce the same result. The treatment of aspirin and steroidal anti-inflammatory drugs should also be considered. Whenever we talk about the platelet function, there are better tests such as the platelet aggregation, which we shall be seeing, and the function of the platelet assay. The specimen is, you need a good technician, and then the sample can be collected in an alley. Now, the indications can be, as I told you earlier, for the platelet function. To assess the clinical history of the bleeding, you need obstetric, dental, surgical, traumatic, and history of drug intake, and any past history of bleeding. These are all some of the indications where this can be done. However, in spite of all this, it is out of regular use. The bleeding time is out of regular use because there have been studies that have been conducted on the hematoma formation after a renal biopsy, but they did not yield standard results. Hence, it has gone into a disrepute. It can be a poor predictor for clinical bleeding, and the platelet function analyzers are superior to it. I hope this is quite simple. It is literally out of practice. As I told you, the number of platelets, the functions of it. Also, the von Willebrand's factor. More important can be the complete blood count, prostacyclin cofactor, and GP1B binding assay. And there are various conditions where there can be bleeding, sepsis, maybe directly or it can be because of the induction of the disseminated intravascular coagulation, drug-induced hematological malignancies, autoimmune conditions. Antiphospholipid antibody itself is an autoimmune disorder. Vitamin deficiency, von Willebrand's disease, DAC, Glanzmann's, Bernard-Soulier, so on and so forth. We shall try to touch upon these if time permits later. There are a few methods of this bleeding time. One is the IVS method. It is a traditional method. As I told you, BP cuff, 40 millimeters of mercury, a timer is set on the moment that there is a puncture. The lancet has got a 1 millimeter tip and almost 10 millimeter width. So in this, the ventral or the volar surface of the forearm is being the site. And there is a filter paper to absorb the blood that is being bled. And once the bleeding stops, that is the end of the test. So ultimately, this is what we had seen. There are the RBCs and then the fibrin mesh in which are entangled the other elements. Ultimately, there is the brick and cement appearance. The normal bleeding time can be 3 to 10 minutes. There are two methods, as I told you. IV's method, it is less than 8 minutes. Abnormal will be more than 10 minutes. And there is another Duke's method, less than 3 minutes, and abnormal itself is more than 5 minutes. Even between these two tests, you people can appreciate the variation in the values. Disadvantage, as I told you, sometimes there can be a closure of the wound on its own. And this itself can prevent bleeding to some extent. The Duke's method, it is 3 to 4 millimeters. And there is a special needle or lancet. Earlobe is one of the sites or the fingertip. The blood is absorbed and wiped. Cessation of bleeding is the endpoint. Timing, as I told you, 2 to 5 minutes. Disadvantages of both the methods. 1, formation of hematoma. 2, infection. There can be a scarring or a keloid. Bleeding can itself be there if the patient is having a bleeding disorder or he is on drugs. It is not a standardized method, as I mentioned earlier, and the interpretation of this can be difficult by the clinicians. So these are the disadvantages you people should be having in. The next test is the clotting time. We have finished the bleeding time. Now we are going to the clotting time. Clotting time, there are multiple methods. Before I go to the next slide, I'll make use of this. There are two methods. One is a capillary method and there is a string method as such. Capillary, you find that there is a fine capillary tube, no graduations or anything. And once there is a puncture of it, you find this is applied onto the drop of blood which goes up by capillary action. And at regular intervals, say about 1 minute, 2 minutes, etc., it is being broken so that you assess the formation of a fibrin, which can be in the form of a string. And that is a fibrin thread. And the clotting time by the capillary method. Another method is immediately without the anticoagulant, the blood is kept on a tube and then with the help of a lancet itself, you try to, at regular intervals, you try to draw it. And at the end of it, I'll be able to see a fibrin strand. That is the end point of the clotting. Fresh sample and the patient should be in the laboratory, no other place. Hemophilia will have to be ruled out and it has again lost its clinical importance. The time taken for the clotting of the blood can also again vary. There are two methods, as I told you, the capillary method with the lancet holding and broken at regular intervals to demonstrate the fibrin strings. The end point is the fibrin string. It is not for mild coagulation disorders, only when the patient is having a massive disorder, because any of these factors, even in a small quantum, are sufficient to prevent bleeding. There has to be a least traumatic collection because there can be the release of the tissue factors which can interfere with the test. Hemolysis has to be avoided, and premature clotting has also to be avoided. A complete history, whether the patient is on drugs or is a hemophiliac, etc., should be obtained. These are the precautions. Not reliable, and a normal clotting time does not rule out other coagulation disorders. Again, variables in the sense in different settings and different hands by different methods, you get different values. There is a little value for routine bleeding time and clotting time. There is another method called the test tube method. In this, the blood is collected. About 2.5 ml, they are divided into the two tubes. In fact, many tubes can be used. And once you keep tilting, you find that at one point of time, there is a solidification. It doesn't flow much. Multiple tubes are preferred. The Lee and White's method is 2 siliconized tubes are there and 1 ml of blood in each, kept in a water bath, and the tubes are tilted at 90 degrees. Stopwatch when the clotting occurs. The disadvantages, as I told you, insensitive variables, and there can be the variables. There can be a thrombocytopenia also, which can lead to a prolonged bleeding time. Normal in patients who are on anticoagulants. It has lost its significance. Normal, as I told you, 4 to 10 minutes, and glass tubes or siliconized tubes can be used. In these also, I find that there is a difference. See, in siliconized tube, the value can be as much as 20 to 60 minutes. Prolonged clotting time can be in afibrinogenemia, decreased clotting factors except 7 and 13, drugs such as heparin. And it is not affected by means of thrombocytopenia, 7, von Willebrand's factor, and mild clotting factor deficiency. You don't have to see the whole staircase. Just take the first step. That is exactly what we are doing. Now we have seen with 2 extremely useful methods which are being done and 2 methods which are almost done away with. But then when we are asked an essay, we should be able to compile a very fruitful and admirable answer. Thank you.